My task will be, actually we are trying to work throughout, come here, say, what do we talk? So being an interventionalist, I mean, we have many topics. So I felt that the complex coronary intervention, I know that audience may not be interventionalist, but there are a lot of things being done and you take care of all these patients. So we update you what we have in this field of complex coronary intervention, in particular area of the calcific lesions. So I have made this kind of a working algorithm that how do we take care of the patients who come to the cath lab. Clearly, and this I have called it as a plaque modification and imaging A cube, but more so for the complex cases. One, we assess the lesion by angio. That's a routine. And then of course some cases do IVUS OCT. Now some data have shown IVUS may be better in particularly more complex lesions. And the FFR. FFR has now become a center stage of our intervention, borderline lesions unless the subtotal, and we do FFR guidance, and that number actually now is about 32% of the PCI based on the NCDR are done in United States with the FFR guidance, which is a very good thing because it has been shown all with a positive outcome, although latest one of the trial we still need to understand, had some as a generalization of FFR was associated with higher mortality, but we still need to understand what exactly it was. But overall, FFR has come into our equation. When there is a question, whether should you do it or not do it, FFR basically decides in the cath lab, and I'm sure this is the same process being adopted here. Then question comes is that yes, you have a lesion, what we do? We do a balloon stent, or should we alter it by some technique, and that is we call debulk and modification of the lesion so that we can have a good result. So alteration, and we do that in those complex lesions of the calcific, CTOs and bifurcation. And also what we have learned that the resistant lesions are the native lesion where the graft was and occluded. Somehow those lesions may not be calcified, but they really behave very poorly for our angioplasty, cause dissections and inability to dilate. So this groups different clearly makes a, based on the practice, 10 to 25% of cases. And after we are deployed and done your technique, in particularly complex cases that besides just an angiogram, you do additional test, IVUS and OCT. And particularly OCT with the bioabsorbable stent, you heard about BVS saga, the Absorb 2 trial with a high event rate at 3 years because they used the technique, but not really to the optimization of imaging. And so, and of course, Absorb 3 and 4 data will be coming soon to see really BVS will have any role in our clinical practice. But key is the post-assessment for adequate apposition and expansion is very important because short and long-term outcomes are dependent on how good your results are. No matter how complex you started, but if your lesion, your stent has been expanded, you are not close any side branch, there is no dissection, no slow flow, that patient will have a very good long-term prognosis. And in the simple lesions, of course, we try with the low TLR. More importantly, in the complex cases, is that to decrease the procedural complication is our most important focus. Because you can have anything outcome later, as long as you have no complication acutely. And of course, what also we learned, that in the past, in this complex cases, we used to give a lot of antithrombotic therapy, 2B3As and so infusions, and that's bad thing. Why? Because the bleeding, which all these agents cause, is associated with higher event rate, mortality, even more than having a myocardial infarction periprocedurally. So clearly the focus has been that to use the anti-pharmacological therapy, but don't increase the bleed. And of course, ultimate goal is that you reduce the TLR. Now, in order to help us out in these complex cases, particularly some with an LV dysfunction, we have assist devices where balloon pump, PTVA and Impella, particularly Impella really has been approved for protected PCI, high risk PCI. And of course, now the new device, which is percutaneous heart pump of St. Jude's, which is a bigger, give you better output, the flow of 4 to 4.5 liter per minute is undergoing the trials. So clearly this field is also exploding in the sense that now with the clear definition, what should be your protected PCI, high risk PCI, the using the device, particularly Impella, is approved by the FDA. And this actually is surprisingly associated with a very good reimbursement, even more than your surgical LVAD device. So So just to say that interventional cardiology has evolved, more and more patients are going to come to us. Even if the trials continue to show that complex cases should go for bypass surgery, it is a general reluctance of the community, and everything falls back on us. And more importantly, patients with a high comorbid condition, high STS score, surgeons don't want to touch them. STS of 5 and above, they actually have higher event rate, and so they usually comes back to our interventionalist. So it's our job in those complex cases, do the perfect short-term and long-term results. So I will talk here of the various, to just concentrate on this field of calcific. So we update you what the data are and say what are the other devices which are coming in this field. How do you see the calcium? To me, simplest definition is from ACC-AHA, which is shown here, mild, moderate, and severe. And basically what we worry about is the severe calcium, which is the dense radio opacity is noted on both sides of the arterial wall. We call tram track, and you can see it very clearly right here. So you don't need any imaging. So some people say, well, I want to see on IVUS, maybe it's a deep wall calcium or superficial calcium, and so doesn't matter. Many times in these cases, doing imaging may even create more problem, because you have to devices, whether it's a OCT or IVUS, may even irritate the plaque. So many of these cases we say once you angiographically, and the data have shown, once you see this kind of calcium, it's a severe calcium. If it is a moderate, which is lesser of issue, then maybe in those cases you may use the imaging, but otherwise angio is a good enough. Second is the IVUS routinely used for identification of calcium, and the definition there is the more than 2 quadrant. So if it's a more than 2 quadrant of the 90 means 180, it's a moderate. More than 3 quadrant is severe. Some people actually also call the length has to be more than 10 millimeter to call it a severe calcium on intravascular ultrasound. So that's how do you see it? Clearly there's no shadow behind this radiolucent architecture. Then OCT. Now OCT actually, some people are very master in. I learned over last few years only, just more for a research tool point of view, to define what is the calcium on OCT. Now you can see this is a clearly demarcated radiolucent shadow is the calcific nodule. Now if it is a fluent, it's not clearly demarcated, it's a lipid-rich plaque. And of course what has been shown, there is no definition of severe or moderate calcium on the OCT. They talk about the length and the depth. And of course, it's very specific in the sense that if any technique can decrease this nodule length or breaks it up and decrease the depth, we'll say that yes, technique is working in taking care of the calcific lesions. So these are the classical or calcific nodule seen as a well-defined shadow on the OCT and so. Now what is the problem? Why am I talking so much about the coronary calcium? We as an interventionalist, we know that this calcium is a problem to because sorry, the regular technique to open the blockage, open the lesion, which we do by balloon angioplasty and then put a stent, are not possible. Sometimes may not be successful because of the calcium. We cannot open, and so, of course, many times the calcium is in the track. You cannot deliver your stent, and you put a stent. You try to dilate, and the result is stent is not expanded. Now you got bigger trouble than you started with, because now stent is there no matter what you do now. Particularly with a high pressure balloon dilatation, you cannot expand it. So this case will have trouble 2 ways. One, high chance of acute stent thrombosis. Second, persistent angina because the lesion is not open. So this is kind of case many of them go for surgery, and I'll show you the case that what can you do. Various atherectomy techniques may help in these cases. Then other issue comes is that calcium also cause the uneven drug distribution because eccentric expansion. So more so for the BVS. So clearly studies have shown that if your BVS is not fully expanded, circular wise, your uneven drug distribution may have higher subsequent thrombosis and restenosis. So all these factors really lead to, from procedural point of view, bad outcome in the coronary lesions. We say, well, I use in calcific lesion high pressure balloon dilatation. Well, maybe, but if you go to a severe calcium, which I defined, even where high pressure will not expand the stent. So this is the data with the bare metal stent. Multiple IVUS runs were done. So while in non-calcific you can open it, in a severe calcium you really cannot open the stent. So it makes sense that you need to do something different than plain balloon angioplasty to take care of these cases. Now, what we have learned over the last few years is what is the predictive value of the calcium which we see on our coronary angio during PCI. I showed you that yes, may have high acute complications and so, but what about the long-term outcome? Actually, there are many trials, and I'll show you a series of them to emphasize that calcium in the coronary lesion during PCI is bad. We all know the calcium on your CT angio and whatever other things that calcium patients do badly, but just coming back to the point that your calcific lesion undergoing PCI, even in the acute coronary syndrome trials of acuity and horizons, remember these are the trial of bivalirudin, other comparison with the heparin 2b3a. So, mild calcium, moderate calcium and severe calcium. Severe calcium by definition is present in about 8 to 10% of cases, which come to the cath lab and getting intervention. Moderate is about another 10 to 12. So, overall if you say moderate to severe, about 25% of coronary lesions have a moderate to severe calcium. So, what does it mean? That even the calcium presence, you have done the intervention and at 1 year. So, we are not even talking about just the acute outcome. Even 1 year that there is a gradient of the calcium with individual MACE events of the death, myocardial infarction and of course MACE and the TLR. So, basically means the calcium is a bad predictor. You say, well, how can that be one lesion and it is not an in-hospital death only. So, why one lesion calcium while you are doing a PCI is associated with this bad long-term outcome, and I will come back to it. Another study, this was actually presented, has not been published yet, combining again from the ADAPT DES, non-calcific, calcific, which is moderate to severe, again 25%, same gradient in the calcific, non-calcific. The third, again pooled study of the 7 trials, the calcific and non-calcific, giving a clear message that is associated with higher MACE event, despite we have done a perfect job maybe in many of these cases acutely. For the women also, it's the same for moderate or severe calcium. Latest paper published from the WIN-DES that all event in the calcific patients are much higher than non-calcific in women also. So, overall the message is very clear. So, could be, and of course, where we have calcium, old age, arterial hypertension, patient smoker, prior cabbage, and of course, low ejection fraction, renal dysfunction. So, this is basically, calcium probably does not mean it's the lesion calcium killing these patients. It is the substrate which is causing this lesion to calcific, and they have the bad outcome. We actually did from Sinai, presented a year before by one of our fellow and has been accepted, hopefully in a few months will be coming in AJC, that determinant, prevalence and impact of target calcium with the new generation DES of our database of 2009 to 2013, 16,000 we use all second and third generation DES, and with the 12,000 patients with the follow-up available in 10,000, basically same message, severe and moderate calcium in 8 and 10% of cases, and predictors of calcific was same, age, lower GFR, PAD, diabetes, and of course the lesion length and so. Somehow actually Hispanics have lower calcium in our database, so this has been a little questionable in some of the studies. But overall tells you the same story, that calcific lesions are, it's not the calcium lesion itself, it's probably the overall substrate of the patient which makes them high risk for the subsequent cardiac events. And this was again, we saw the same gradient which have been shown by earlier studies of the non-moderate to severe calcium of various MACI. The answer comes very simply is that non-cabbage major bleeding based on the calcific score. And you can see here severe calcium, moderate and none to mild, that there is a gradient. So, what does it mean? So, that patients who have coronary calcium have rest of the vasculature calcified. The data also has shown the calcific patient going for cabbage, they had a bad outcome compared to non-calcific lesion. So, it's not only for PCI, even for cabbage also. So, basically emphasizing that calcific is the bad substrate for subsequent event, vascular, bleeding and so, and that very likely is causing their bad outcome in the future. So, you always have to worry about, so if I alter one lesion when I am doing a PCI, how am I going to change the prognosis of these cases? That clearly remains the part of the discussion. But yes, as an interventionalist, you don't want to add to this the event rate of these cases. See, actually, to answer that question prospectively, we did the trial MACE, which was 350 patients. And what basically we did is prospective evaluation of the baseline calcium and see how resource utilization and complication in the current era. So our trial was 1 year was completed as of December last year. We have sent this paper for late breaking trial for ACC. Haven't heard for that. So basically this was the number. Now I can tell you that severe calcium in United States, and we are talking about in 2015, that how many patients are getting the atherectomy? Dr. Kleiman, what do you think? Yeah. No, overall, yes. But in a severely calcific lesion, 25%. Just about close, 32%. So just to say that still, that calcific majority of our lesions are being treated by non-atherectomy techniques. So right or wrong, but that is the prevalence, that is how we do. And Dr. Kleiman was correct that overall, while 8% severe calcium is present in coronary lesion, the intervention, the atherectomy is used in about 4% of cases. That number actually 3 years ago was only less than 2%. Reason is now we have additional, particularly orbital atherectomy, and then now there is a better reimbursement. In the past, until 2 years ago, atherectomy was not added part of the DRG. Now it's the APC3. So clearly the reimbursement doubled, so hospital does not lose money on the atherectomy. And of course, that was part of the MACE. And so just to say that whether changing our culture, our behavior, using more atherectomy in these calcific lesions, who we know don't do very well with the balloon angioplasty, before putting a drug-eluting stent, it will change the outcome, we do not know. So basically, how do we take care of these calcific lesions? Clearly, if you are mild to moderate, use a high pressure balloon dilatation, we call them non-compliant. Sometimes we leave a wire side by side and cut the lesion, or we have the scoring balloon techniques and cutting balloon, which goes to moderate pressure and take care of the mild to moderate calcium. You don't need in the regular one, but in the moderate calcium. The severe calcium, we actually have two techniques with added on the third one, and these are the rotational atherectomy, which comes in various sizes, and the burr is at 150,000 RPM, and the second is the orbital atherectomy, which is only 1.25 millimeter crown. They call it a crown. Rotational atherectomy, we call it a burr, and it's a 80 to 120,000 RPM. Soon there will be another crown will be available called mini crown. We have done the studies on that of 100 cases, has been presented to FDA, which also has a tip abrasive surface, will be available soon for orbital atherectomy. Then the laser, ELCA, for the same purpose. As I mentioned, the atherectomy is getting the second breath. The people started using laser also. It's available in various sizes, and I'll briefly discuss and show the use of these three techniques in various of our calcific lesions. Now, rotational atherectomy is there for the longest since 1992, and basically it's a diamond microchips in this conical shape, and which works on the differential cutting. Basically, elastic tissue deflects, non-elastic tissue ablated. One of the big issue is the specialty wire, which is called Rotawire, which has a 0.009, and it's a very flimsy wire. That's one of the big limitation, and the whole setup is very complex. There is a separate nitrogen tag, there is a tachometer, there is a paddle, so all complexity of the rotational atherectomy, but still, this is the oldest device which stood test of time for the atherectomy, while many other devices like DCA, TAC and all have disappeared over time. Basically, differential cutting principle and orthogonal displacement of friction are the two techniques. Now, while rotational atherectomy is good for the calcific lesions, it does have some issues, which is for any device. The most common being the slow flow. What is the slow flow? So once this burr comes to the calcific lesion, it basically turns into a powder. So those particles, how they go? They go to the microvascular system and taken up by reticuloendothelial system, but they can clog the capillaries. If the whole technique of the rotational atherectomy is that how you can do it correctly, so you generate is just a limited amount of this debris, athermatous debris, which can be washed out to the microcirculation, and that's I would say, the very much technique dependent, and that's really reflect your occurrence of slow flow less or more. So mechanism of this potential or dreaded complication is atheromatous debris embolism, platelet and microthrombi, platelet activation aggregation by Rotapro, and of course the microcirculatory spasm. So purpose there is more importantly that anytime when you do rotational atherectomy, if you really decrease the blood pressure, because now you have caused the stenting of the myocardium, so your gradient of the mean blood pressure to the across the coronary flow decreases. So we always make sure that your PC, your aortic pressure remains good, which I call it a systolic pressure in triple digits. When you are doing the intervention, if need to be, give neosynephrine or dopamine so that you don't create the slow flow, and this process of slow flow does not occur, which is one of the dreaded complications, because then you have no chance. You may use any adjunct devices. Surgery is not an option for these cases. So idea should be to decrease the slow flow as much as possible. Now, the story goes back, if those remember, Orbital trial, where laser, rotational atherectomy, and balloon angioplasty was compared in B2C lesions, and basically you can see what did the Rota do? Did a better procedural success. But as far as the restenosis, we actually lost to even PTCA in these complex cases, just a simple balloon angioplasty. So yes, technique is good for acute, but for the long-term point of view, rotational atherectomy did not show benefit. There are multiple studies have been done to answer that question, and so many trials, all of them representative being the latest, which was done in last 5-6 years using the rotational atherectomy in moderate to severe calcific lesion in Germany, half about 240 patients, half to rotablation plus tax stent, other half to just PTCA and the tax stent. 2/3 were moderate calcium, 1/3 was severe calcium, and basically the primary endpoint being the angiographic follow-up. So what they found basically, that once you do rota, you need a bigger guide catheter, 7 French, because 1.75 bar can be used through 6 French, and of course you need a bigger and cause extra procedural duration, more fluoroscopy time, which is the normal that once you use this adjunct technique. But more important is the outcome point of view, as you can see, that by doing the rotational atherectomy in this day and age, I would say probably recent day and age, because it's about 5-year-old trial, that you have a better success, strategy success of the device. You are able to open the lesion. Now, if you didn't use it, what happens? You lost stent 2.5 and crossover in 12% of cases. So clearly, it makes sense that in this moderate to severely calcific lesion, doing a rotational atherectomy from procedural point of view is good. And of course, in the end, equal results, but more importantly, 9 months, again, no difference in outcomes, no difference in MACE, restenosis, MI, TLR, and so. So clearly, this is frustrating. So question will be that why, and I'll come back to that question very shortly. So why this happened, that despite your better procedural result, the rotational atherectomy does not translate into a good outcome. Reason is, look at the lumen loss. Your late lumen loss is much higher with the rotablation compared to standard therapy. Very simple. Rotational atherectomy, the technique we use, high speed, probably cause more injury to the endothelium and cause more intimal hyperplasia. So this heat damage probably translate. Second, the part of this study also came that if any of those events which occurred, 32 in rota group and 37 in standard, did we delay any of this time-dependent occurrence of MACE? No. So overall, rotational atherectomy did not make any difference in these patients. So why? One is the complex setup of the device and the long learning curve. This might change because we have the new Rotapro system, hopefully will be available within 6 months. That's expected by June, July. So no more your tachometer, no more your paddle, everything is just on the table. And of course, they still come with the tank, but much simpler. And secondly, maybe a better rotawire. So technical advances are taking place in this rotational atherectomy field. Although very effective in ablating calcific lesion, there are still some procedural complications, as I mentioned, the slow flow perforation dissection. And the key is the restenosis is not decreased by rotational atherectomy, likely due to heat generation and thermal injury causing higher late loss. So can you change that? Maybe the slow speed, although recent data showed one study that there was no difference in slow and large, the regular speed. Slow speed we call 150,000 RPM. The high speed we call 180 to 200,000 RPM. So usually now we use 150,000 RPM. Whether will it make a difference, it need to be seen. So therefore, we needed some other device. So rotational atherectomy was there. This field is gradually exploding. So second device is the orbital atherectomy. Came in October of 2013, which is easy setup and has a better wire compared to 0.09, now 0.012, and compared with the 6 French, fast learning curve, less slow flow, and everything is on the table. Just like the Rotapro, which will be made now. So all the speed, knob, adjustment, all here. So nothing separate. So clearly the 2 is here 80,000, 120,000, and this is a very complex conical burr, very eccentric. So it's actually good maybe, because what happened? Once your cone goes to the lesion, it occludes. But if you're eccentric, so you are not occluding the lesion while the device is being done, while the ablation being done. So that may be the plus point, and this is how basically it works. That you can say, well, it's really causing too much trauma to the vessel. It looks that in animation, but overall, in these calcific lesions, that is probably what we want. We want a fracture of the calcium, whether it makes a debris or not doesn't matter. So our stent can further expand. And this actually has shown that you change the speed, you have a more vertical movement of this crown and give rise to a better lumen, and the slow passage of the device is very essential. Again, small particle, actually turns out to be the particle are even smaller than what we generate with the rotablation, up to 2 microns. Rotablation is usually about 4.2 micron, so clearly half the size. And what the purpose then means, it will cause less slow flow. And it's also some technique dependent that you need to go slowly. And of course, you go to 80 or 100,000 RPM. Although burr is only 1.2 millimeter, 2.5 millimeter, it can give you a lumen of 1.5 or 1.7 or 1.8 based on the speed what you use. So basically, my recommendation here is by using it, the 80,000 RPM at a 1 millimeter per second is good enough. You don't need to go to 120, because 120 is the one which causes more complication and perforation, and that actually has been my great teaching to the orbital, the CSI, which are the manufacturer of the orbital atherectomy. And since then, their recommendation also changed to just 80,000. Their complication, the perforation had decreased significantly. So basically, it is based on the data approval of the device occurs by some studies, which is Orbit. Orbit 1 actually of the 50 patients were done in India, all with the good results. But now we have Orbit 2, which led to the approval of the device in 450 kind of lesions with a good initial success and overall complication rate under 10%. So you say, well, this is kind of a usual. So I want to surprise, maybe with the rotational atherectomy, this number may be about 15, 16%. And so, but nothing different compared to what we'll have this from safety point of view using this device in the complex lesions. These are the individual complications. One of the very important one, as you can see here, slow flow is almost non-existent. 1% slow flow occurs even without regular PCI. So clearly the device is very effective. Of course, there may be a perforation slightly more than rotablation, which is about 1%, but overall very effective. These are the various comparison. Slow flow lower, and the perforation wise right middle. Many of the rotablation is the lower perforation than orbital atherectomy. So now we have the data up to 1 year, and that's where the whole issue comes. Remember the trial of the ROTAXUS, which we showed. There was 15 to 16% TLR at 1 year. Now this number is about 5-6%. Is it fluke? It's a 400 plus cases. Now we have the data up to 2 years. The number amount remains around same, 6 to 8%. So maybe now we are seeing some effect of the atherectomy decreasing the incidence of subsequent restenosis. We understand that acute complication occurs in a small percent of cases, but you need the device to have a good outcome. But and if you compare them, so this is the Orbit 2 DES up to 2 years, and that number is far lower than any published DES in this calcific lesion, including the ROTAXUS. So makes sense that maybe the use of orbital atherectomy will be associated with a lower TLR at follow-up, and the data basically that why we have a better results. One, continuous flow during orbit, possible prevent thermal injury and may wash particle downstream and less slow flow because of the crown it is. Second, short duration and the unique mechanism of action designed to treat entire lumen, differential setting and sending in a small particular size. So here, it seems to be that we have another technique which now have come added to our atherectomy armamentarium, may be associated with lower TLR and TVR at follow-up, although acute complications are basically numerically similar. And of course, this is the only device which has been used for the calcific lesion, although we use rotational atherectomy, but they don't have a product label for that purpose. So now, to answer this question in a real way, CSI has a big, I would say, gutsy to partner to announce a trial of using the orbital atherectomy called Eclipse trial. And this will be the first of its trial which will show the efficacy of the plaque modification in the moderate to severe calcific lesion in the 2000 patient, clinically endpoint driven, half getting orbital atherectomy and DES, other half complex conventional PCI. You can use a specialty balloon, but no rotational atherectomy. And DES and 1 year follow-up with the primary endpoints. They have put 2 points. One is the post-procedure lumen based on the subset on the IVUS, and more importantly, clinical outcome of the target vessel failure at 1 year. So this will be the first large-scale randomized trial which will start in next few months to answer this question whether atherectomy makes sense to improving the clinical outcome using orbital atherectomy in these calcific cases. So people ask, of these two techniques, which one is better? It's OCT or rotational atherectomy. There's no comparative data. We actually have given our data we have sent to for publication. The problem is that we do 80% rota and 20% OCT. So this so the orbital atherectomy, so they actually have been declined. We are getting some more experience on the orbital atherectomy point of view. So no randomized comparison, but we did publish one mechanistic the trial of 20 patients with the OCT, rotational atherectomy and orbital atherectomy to see that what causes, which device cause your better lumen change. And basically what we saw that this is the rotational atherectomy, this is orbital. Look at the cut. While rotational atherectomy makes these cuts, orbital really cuts deep. So this is the device, this is actually early. Some of the cases were done with the 120 of the 10 cases, 3 done with the 120 and 7 done with the 80,000, but basically shows that really caused deep dissection. Now case example. So this is the case, calcific lesion, and this is the post-orbital atherectomy, looks good, and this is the OCT, and you can see here the deep cut has been created by the orbital atherectomy, basically the device going vertically, not only longitudinally, vertically cutting the plaque. Then this is the final result, excellent, and you see by the OCT, seems to be that stent is better expanded by using orbital atherectomy, and exactly that is what we saw. That cut length by orbital atherectomy much deeper, which you say, well, maybe good or bad. If you are a little much deeper cut, you can cause more perforation. Second, that dissection depth, as I mentioned, bigger, but more importantly, percent of mal-approach struts much lower with the orbital atherectomy compared to rotational atherectomy. So clear, what does it? It expands your stent better, and that lead to the overall stent expansion little better with the orbital atherectomy compared to rotational atherectomy. This is a small study. We are actually doing a few others now at present which are ongoing to answer this question in a comparative mechanistic way. You cannot do such a large study which have been they are going to do with the Eclipse, but at least to answer the question that which cases you use rotablation versus orbital atherectomy. Personally, at our center, we actually have almost no perforation with the rota. We did have with the orbital atherectomy about 2%, but all of them were done with the 120,000 RPM speed. So once we went down to 80, we have no perforation even with orbital atherectomy. But key is it may make sense, and that actually become more important once you go to the BVS, the better stent expansion and so. So let me just show you few cases. This is the case which we did at the CRT of patient with a 3-vessel disease and left main, low ejection fraction. The patient had heart team discussion, no cabbage was declined, and you can see here clearly the bad LV. Very calcific. This is the severe calcium. Calcific of the left main, tram track, LAD, very slow flow of the LAD. Now you can see in this better view here. Subtotal, this was the live case this year. Right coronary was fine, but again very calcific. Put a impella in this particular case, and then after atherectomy, you start seeing the lumen dilatation and post-dilate with the high pressure. And even if you have done the moderate atherectomy, that your full stent expansion will take place and side branches will be preserved. And this is one of the important for the atherectomy, that you don't close the side branches. And so clearly on all these devices, as we know, that you remove the support device at end of the procedure. Second case, which they asked me to present in the SCI meeting last year, that patient had a PCI done 9 weeks ago, troubled stent case, or we call the regret. This patient, you can see here, fish mouth appearance of the stent, right there. It has not been expanded. Now do what? Big trouble. Patient, you can do any balloon, they did a multiple, would not expand. So there are very limited options. What has been in the past that you can use a laser by vaporizing atheroma, and particularly the plaque behind this calcific that may subsequently expand. And another question is that you can use the atherectomy. So this patient otherwise was okay. So first we use the orbital. So we say, well, let's see whether orbital will work to expand this. So did the orbital won't even cross? Orbital atherectomy did not even cross. And we actually have published the data on the rotational atherectomy of this unexpanded stent. So in this case, after 1.25 of the rotablation, balloon dilatation, stent expanded, and then of course you have to re-stent it, and came out good. And I have angiographic follow-up in this case after a few months and then remain fine. So key is that some case of this unexpanded stents can undergo atherectomy also. So question comes, where do you use rotational atherectomy? Where do you use orbital atherectomy? This basically principle, your burr conical shaped at the ablative surface at the tip with the 0.009 wire, with the orbital eccentric crown and very stiff wire 0.012, particularly aortosteal lesion, angulated lesion will cause less dissection by using a rotational atherectomy and in the large vessel. Also, unexpanded stent, because of that heat generation, rotational atherectomy is a preferred approach. But majority of the cases you can use either of the device. But orbital, by the ease of setup, fast learning curve, less slow flow, so the hemodynamic and stable patients, maybe orbital atherectomy is preferred. So just a few words of the third atherectomy, and that is the Lesion, which basically works with the photothermal, chemical, and photomechanical basic in the calcific lesions, and the two catheter size 0.9 and 1.4, various energy 40, 80 and 40 joules. Potential indications, particularly with the calcific lesion. A lot of data have been published. Recent data called Leonardo study of the 100 calcific lesions. The success rate was about 94%. In about 6 patients, the device did not even go through the calcific. So I kept it in a very low area in terms of recommendation using laser for the calcific lesion. And so this is the type of case. This is the case actually we did. You have put a wire across, and now you cannot change it to the rota. This is the totally occluded right coronary artery. We could not advance the rota wire, but your other wire can cross, and in that case, we use the excimer laser to open this uncrossable lesion, subsequent dilatation. So that's where basically excimer laser is used. The lesions which are not crossed, and so there is another device which is coming in this field. The field is not end yet. There are many others in the literature going on with the first the animal data, is the lithoplasty, shock wave, just like we dissolve our renal stones and gallstones. So this is coming to the coronary. Shock wave therapy basically in a calcific lesion. The purpose there is that it will cut, or I would say that basically disrupt both deep and superficial calcium, and it goes over the wire 0.014, goes through the lesion. The data were presented in a small group. Actually, device is approved for the peripheral, but for the coronary indication has come being used now. but you'll hear more about this technique in this calcific lesion, and maybe the small number of cases which were shown that associate with a lower slow flow, and so need to be seen. So just to sum up few things, that the plaque modification strategy in calcific lesion, rotational or orbital, atherectomy is an adjunct tool to improve procedural success and may improve long-term outcomes. TLR reduction still needs to be proven by randomized clinical trial with using orbital or rotational against your standard of care. And I say very simple, the atherectomy makes your complex lesion simple. So particularly with the calcific lesions, and once we are getting to the BVS, really the plaque modification will take the center stage of our intervention. So this review we wrote down a few years ago, which actually puts it together, how we take care of these cases, the patients with a functionally significant, based on the FFR or significant angiographic stenosis. If they're complex, left main multivessel high syntax score should go for surgery. Many of them, they decline. And of course, those who are low syntax score, based on the angiographic calcium, if it is a severe, you adopt one of the atherectomy technique which you are good at it. In the moderate, to decide whether you need atherectomy or not, you can use IVUS or OCT. Other cases, you can start with a non-atherectomy, but if you fail, you can always use the atherectomy technique to get your good results. So this basically sums it up. Overall, we do about 15% cases with atherectomy, 1/3 as a orbital. And just to give you overall number, the number is actually going down in terms of the interventional volume. This is actually shown at Mount Sinai. We used to be 5,000 plus, now a little lower. But more important is the PCI volume, which is the national trend, has kind of gone down, but growth is taken by our the structural heart, tremendous success of the tower program, and putting together that all complex lesions with the combining your technique and the devices and of course pharmacotherapy has really resulted in an overall complication intervention being less than 0.8%. So last year actually somehow unfortunately we had a few more in-hospital deaths, but still the majority went home. I mean only 14 did not go home of this 35, 36 patients, and we all know that with the techniques where rarely patient goes for urgent bypass surgery. Now the last slide to compare, this is the data of the latest one of the New York State, they usually give a few years behind. So this is where our volume and the 30-day risk adjusted mortality, that's where we take the pride in it, that making it in New York one of the busiest as well as the safest. Double star means very good, 1 star means bad. If you don't star, you're okay. That really continues to advance this field, which the next point is the education with the webcast. This actually I started in July of 2009 with the complex coronary cases, CCC Live, every month, 3rd Tuesday from 8 to 9. And then of course the one will be this on January 17th. Peripheral we added a few years ago, now added structured live webcast, and usually about the coronary, coronary cases, about 6,000 views per case. I have a moderator, ask the question, and then of course we have a good discussion from various people's input. It's usually live telecast in 132 countries, but the idea there is that how can you educate people to do the right thing? And I would say this mission using with the live webcast has been very, very successful. And thank you very much. And I can take any questions. Yes.
Congratulations. Wonderful experience that you've shared with us. Thank you. Calcification is an even bigger problem in peripheral arterial disease. Would you like to share your perspective with the rotational atherectomy, orbital atherectomy in the periphery?
Yeah. So actually, I just aware of some literature that kind of orbital atherectomy has gone away because they somehow created more slow flow, I was told. So we do use rarely orbital atherectomy for the peripheral interventions at our lab. Dr. Prakash Krishnan is the endovascular director. They do lot Silverhawk atherectomy. but as far as the orbital atherectomy is done, very little. We do about 18 peripheral interventions a month, 80, 85, and orbital atherectomy may be 1 or 2 cases. So the reason I was told that somehow they have more debris with the orbital atherectomy, and that's why it is not used there. So I'm a little surprised on that, because coronary, there is no question that we have seen lower slow flow, although with the rotational atherectomy it's quite low anyway, but definitely with the orbital, one advantage is that it creates a less slow flow. Yes?
Dr. Sharma, can you explain a little bit more on how to use rotational atherectomy and stent, and you understand the sizing, when do you stop, when do you know how much you ablated, and a little bit more technical aspect of it. Can you just?
Yeah, that is basically for unexpanded stent, right? Yeah. So very good. That's the important point, is that you have an unexpanded stent case has been sent to you. Why? Because if you would have been in your lab, you would have used the atherectomy and stent would have expanded. That doesn't happen in the lab where you are. So we always say that it was sent to you. So now the question is what to do. So clearly use the smallest bar. And actually I have, one of my review back in CCI, few cases, even the atherectomy, rotational atherectomy did not cross the lesion, this unexpanded stent, but it goes inside and stall. So I say that even if the lumen, like this particular case I showed, use a 1.25 rotabar, slowly advance, and not uncommon, as soon as you come to the unexpanded area, the burr will stall, red light on your tachometer. You pull back, try again, could not do, but that's okay. But what it has done now, that this rotabar, which was 150,000 RPM, has become 0. And what the result? It has heated that metal, the stent metal, didn't cross. So very rarely the data are there that you go through in unexpanded stent, that rotabar, they have seen the particles going downstream, that the diamond chips can be taken care, they can embolize downstream. You really don't ablate the stent, but basically you heat it. And all those cases, even if the rotabar did not cross the lesion, your subsequent balloon dilatation opened it, just like what Excimer will have done. Excimer basically evaporated the atheroma behind the stent struts, so you expanded it. Here, now the heated metal has really liquefied the calcific plaque. So that, in my opinion, is the mechanism of the rotational atherectomy in the unexpanded stent. It's not the metal ablation, it is the heating of the metal.
So I had a similar case like you showed for the LED, the fish mouth appearance, except that this was distal LED, heavy smoker, gypsy guy, completely restenosis LED stents, started with 45 centimeter sheath, WODA guide, wired the LED, that was not able to get guide liner in, everything came out. So in the distal LED stent, it was an underexpanded stent, heavy eccentric calcium. I could not get anything down, change wires. Finally, with Whisper wire, we were able to get one balloon in. I expanded the balloon. The plaque expanded. I put a 2.25 stent to cover distally. 2 weeks later, I don't know the compliance with Plavix, etc. is a question in this guy, but 2 weeks later, that area appears unexpanded. Do you think stent recoil in these lesions, once you have expanded the stent, is a problem?
Yeah. So the question comes is that there was a case of very calcific lesion, and that does the stent recoil occurs? Well, I would say the stent recoil is not an uncommon feature. It has always happened in the past, and particularly if you still have calcium from outside, some recoil, we have seen it many times. Now, many of this recoil is that the plaque has gone inside the lumen. So if you do the IVUS, although with the apical LED may be very difficult to do it, but you see that it's the stent, but more importantly, it's more of the plaque and calcium has gone inside the stent now and creating this the appearance of the recoil. But yes, stent recoil is a well-known phenomena and can happen, and I have personally seen it also. Yes. Neil?
So, Samin, that was a great talk, and it's very, very clear to us that you've got some insights that none of us, at least on this side of the podium, have. So one thing I'd like to probe a little bit is this. The techniques are dynamic, and the way we do rotational atherectomy now is very different than the way we did it 20 years ago, or even 10 years ago when the data were accumulated. So smaller burrs, lower speeds, less contact, more rapidly we exchange the burr for the business device. So tell me how, and now as I watch your presentation, I see that happening to orbital atherectomy too, lower speeds. Maybe you're going to get a little more conservative about what you do once you've crossed the lesion. Tell me how you think that affects the way we interpret the data that really have been accumulated probably before we do what we do now.
Yeah. So I think this is a very important the question asked that what is the impact of the change in technique in the outcome, and particularly now with the rotational atherectomy, which has been here for 5 years, and we still don't feel great about it in terms of the long-term outcome. To me, answer is actually there is no clear answer. Only we can talk about our personal experience, that what slow flow perforation we used to have, that has disappeared with the rotational atherectomy by going to the slow speed. Lower CK release, that actually we published back in 2002, when initially we changed from 180,000 to 150,000. So it's just more of a personal and anecdotal experience. But I still believe, so one of the Achilles heel, or the important Achilles heel of the rotational atherectomy of the restenosis, is purely driven by the heat generation. Why I say that for sure? Reason is, even the ROTAXUS trial, they had a better lumen gain acutely. So lumen was better with the rotational atherectomy and stent versus PTC and stent. But then you paid the higher price. So what is the reason higher price? It's some kind of a barotrauma. Now what is the barotrauma with the rotational atherectomy? But is very small. So it has to be that it's the heat generation which has created a more barotrauma or intimal hyperplasia, which translates into a higher restenosis. So therefore, so my contention has been, and then particularly with the Boston Scientific, so if the CSI perform their device and they do the trial against conventional technique and they come as a winner, the whole country will adopt orbital atherectomy and rotational atherectomy will disappear. So it is equal that with the latest data of technique, as you mentioned, that we need to do trials using rotational atherectomy and really see the outcome of those cases.
Well, thank you, Dr. Sharma. Your presentation was very insightful, and thank you for sharing with us. I have a question regarding protected PCI. So you obviously share your passion with us in terms of doing atherectomy cases in all this complex environment. So vast majority of your patients probably are of advanced age and low EF and all this complexity. So what is your threshold in using Impella-like devices? How routine is it? And what are your indications, if you can share some insight?
Great point. So protected PCI is the new terminology which has been coined by of course, the ABOMAD, more important for the FDA, based on the PROTECT trial. So basically that the device has been approved, Impella, in those cases with the LV dysfunction, with the 3-vessel disease EF of 35, or with the left main EF of 30%. So as I mentioned here, there's about 300 PCIs which we do per month. We use about 15 cases with the Impella. So basically it turns out to be about 4-5% only. Another 5-7% are balloon pump, and those are usually acute MIs. So we don't use the Impella for the acute MIs cases, but high risk cases. And the other 5-6-7% is the balloon pump. But is about, I would say, threshold having 5%. Reason is because nowadays will be a very high ticketed item, and those are the one which we all have to worry about the subsequent audit that we are doing the right thing. So clearly, what is the indication on the PROTECT trial? We are completely fine, and the patients who have low ejection fraction, 3-vessel disease, or left main disease, the question only comes that if you have isolated single vessel, 90% proximal LAD and EF is 15%, should you use it? Again, based on the recommendation, you can justify that case. That 15%, even if it's a simple lesion, single vessel, but single vessel is the important vessel supplying the viable myocardium, so maybe justified. But other two groups of the EF of 30 and 35 with the 3 vessel and left main, respectively, is completely justified. So it's about 5%, I would say. Yes.
Samin, I wish I could clone your enthusiasm and your energy, and maybe even more importantly, clone your skill at doing this. For example, the case you showed with the left main and LAD, extensive calcification, I'm pretty sure I would have sent that patient to surgery. The distal targets looked okay. So my question is, what do you think the advantage of doing an interventional procedure that a small percentage of operators in the country could skillfully accomplish versus bypass surgery for some of these lesions? Do you really feel there's a benefit to?
That's a very good point, and particularly again based on the recommendations. And as I always say, whatever we do, we just always think about, no matter how good you are, somebody else is watching you. You will be under scrutiny. So basically, that type of patient, like the case which we did, and we even did for the CRT, the live relay, has to undergo the heart team discussion, the surgeon. Now we know that, and I'm sure you have the similar experience, that despite the interventionalist referring patient to the surgeon, half of them will come back to you. So this is actually the story. We follow that, and we have the whole complex syntax score algorithm which we share with our surgeon, president of the hospital, and so, and have clear-cut documentation. So surgeon will talk to the patient, and the cardiologist, we say that heart team, although we say interventionalist, I would say interventionalist should not be part of the heart team for the complex CAD, because we have recommended should go for cabbage. So you already have taken out interventionalist. It has to be now decided by the family, patient, and the referring physician with the cardiothoracic surgeon. The problem is that no matter what, it is the normal human tendency. Despite you tell them, whether with the freedom trial results or the complex syntax trial results and so, that you live longer by doing a cabbage, half of them will come back to you. That particular case actually was referred to surgery. They actually wanted the first, and you know, with the LV dysfunction, surgeon always want the myocardial viability. We pay less attention to myocardial viability, but surgeons pay a lot attention to the myocardial viability. Yeah, I mean, that's true, because so that patient was viable in the anterior wall, quite viable despite their LV function. Still surgeons say, oh, but the patient has, we have a discussion with the patient, and patient does not want. So coming back to the point is a very important point, that we need to follow the guidelines. Patient with the high syntax score, plus minus left main disease with a 33 and so, multi-vessel diabetics, should have a surgical consultation discussion before comes back to you, and I can guarantee you, you leave this process alone, 50% will come back to you.
I have 7 or 8 more questions, so I'll only ask one. Bifurcation, 2-stent bifurcation technique of choice these days. So when I was there, and I still practice the same, it's the SKS and the modified T. Is there a change with the, the tap technique and the modified culotte with optimization? Has that been incorporated in your practice?
Yeah, actually, you know what, I wanted to add that with the 1 or 2 points on the bifurcation and maybe CTO, but I said they will confuse the issue. I gave a lot of data. So one thing what we have learned, and I can sum this up, and I know that getting past the time, many of you have some other activities. The key is, what 5-10 years ago, we said, oh, all cases should be is the crossover or conventional stent, one stent strategy. What data have accumulated now over the years is with a mini crush, with a DK crush, and some culotte done correctly. So there are lesions where 2 stent will be better than 1 stent. So answer is not that you do 1 stent or 2 stent. Answer now is identify the lesion which will do better with the 2 stent. That basically means that 25-30% of your conventional stent technique, which would have needed 2 stent, that you identify them beforehand and go with the plan 2 stent strategy. Do not be intimidated by, because enough data in the literature have come now that in some complex cases from Cobis bifurcation registry and so, and of course the DK crush 2 and 3, that 2 stent approach may be better, actually not maybe, is better compared to one stent approach. And those cases you need to identify, and basically those are the cases with the narrow angle, long lesion of the side branch and large side branch. So now coming back to the point, what is the preferred approach? DK crush, which is a multiple step technique, we don't use that often, but mini crush. The left main, maybe SKS, but rest of the non-left main, mini crush technique for the two stent bifurcation is the preferred approach, and that is being used in about 28% of the bifurcation lesions at Sinai.
One final question, and that is, there are now non-compliant balloons coming in which can be inflated up to 40 atmospheres safely. How do you think that will play into this entire calcific lesion?
My only question is, the perforation I see in our lab happen with a non-compliant balloon or using an angiosculpt or cutting balloon, not with the atherectomy. So if you're using a severely calcific lesion, you're non-compliant. You may open some of the lesions, but that's where your perforation occurs. Okay, thank you very much.